So first things first, we'd love to get a sense of where everyone is physically located right now. So if you could just click the chat button on the bottom and go ahead and tell us where you are in the world. Where are you joining from? Wilmington, Delaware, Indiana, North Carolina, Palm City, Florida, Memphis, Tennessee. Oh, wow, there's a lot. Great. California, Detroit, Michigan, Tennessee, Pennsylvania, Memphis, Tennessee. You brought a lot of folks, Ingrid. I am physically located in Cambridge, Massachusetts. And my name is Allison, and I'm a community facilitator for the Northeast and Mid-Atlantic region for ACEs Connection, and so grateful that you all are here. So let me just tell you a little bit about the structure before I hand it off to my coworker Ingrid, who's going to be hosting this conversation. So first, we will introduce some topics for all of you, and so there will be a little bit of listening. However, we're wanting this to be a discussion and to be interactive. And so you can put your question or comment into the chat. And then when we pause and take a moment for that, what I will do is go over to the chat, see questions and comments, and I will call on you. And at that time, I will make it possible for you to unmute yourself. And then you can share your question or comment to the group. If you are not wanting to be called on to say it out loud, which we may or may not get to your comment, you can just say, no need to call on me, or that kind of thing. So you can actually make a note. That's been working really well. For example, if you just drop a resource in there, we probably won't call on you if you're responding to someone and you have a good, a YouTube video or a link to a resource, you can just drop that in there. We probably will not call on you unless maybe we want some more explanation about your resource, or we feel that it would really add. But other than that, put the comments in the chat. That's how we will call on you, and that's how we kind of keep the order going, because there's so many of us. And so without further ado, I would like to introduce you to Ingrid. She's our community facilitator of the Midwest region and Tennessee.
Thank you, Allison. Can you guys hear me? Okay, good. So today we wanted to talk about health equity, especially during this time where we are in the COVID-19 pandemic. So when Jane reached out to me, our founder, Jane Stevens, reached out to me to think about what topics I wanted to discuss and how I wanted to be involved, I said health equity would be the best way for me to interact during this time. And this was way before they started to put all the data in the news. So this is very timely, and it worked out well. So that's what we'll discuss today. We're going to talk about systems, all of the ways that the system that we have here in this country is impacting the health of people of color. And we're going to talk a little bit about history. We're going to talk about present day, so it's going to be a variety of topics. First thing, when I thought about this topic, I wanted to ask Joshunda Sanders to join me as kind of a co-host, and that's because of a recent conversation that we had that I thought was really good, and I think that it would be great if she could add her perspective. She is a former speechwriter for the Director of Health and Human Services during the Obama administration, specifically the Office of Minority Health. She's also a New York native, which is kind of the epicenter of our outbreak here. So I would like to introduce her now. Joshunda, please introduce yourself to our audience.
Hi, everyone. I'm Joshunda Sanders. Thank you so much for that introduction, Ingrid, and for your work, and Allison, your work to help convene this really important topic. As you mentioned, I live in the Bronx, which is actually now Queens. Things have shifted so that Queens is the epicenter of the epicenter in New York in terms of the number of COVID-19 cases. But it has been interesting being in the Bronx to see the number of health disparities that have been unveiled and come to light in recent days. I worked as the speechwriter for the director of the Office of Minority Health during the first part of the implementation of the Affordable Care Act. And so we looked at a lot of data and measures of uninsured Americans and, of course, people of color, women, so I've just kept an interest in how that data tell a story about healthcare access and how we can sort of start to shift some of those things.
Yeah, thank you very much. And so I always like to frame discussions. And especially because I like to look at things from a wide view. When we talk about racism and disparities and inequity, it can be difficult if we don't have that frame, because we tend to, as Americans, we tend to fall into individual. This is an individual problem. This person doesn't have a healthy lifestyle. This person doesn't make good decisions. And what we need to start doing is see the big picture and think about all of the systems at play in our society in general, not just America, but in our societies. And those systems are what matter when it comes to overall health for our country. And I like to talk using Bronfenbrenner. He is one of my favorite theorists around human development, which is my specialty, because he talks about systems. He is one of the reasons why we have a head start. And he said he believed that human development happened within different systems that work together, and all human development, to include health outcomes. And so when we think about what's impacting communities of color and people who are vulnerable during this pandemic, we have to look at all the systems. We have to look at the huge macro system. What are the attitudes that we have about people of color? What are the attitudes that we have about health? What are the attitudes that we have about people living in poverty? Not just our individual attitudes, but our pervasive attitudes as a society. We have to look at the laws that we have in place. What policies, rules, regulations are more restrictive or target people of color, people with disabilities. And then we have to think about those neighborhood environments. Who has lead in their water? Who has more pollution? Who has less access to a healthy diet? Whose neighborhoods have high rates of violence? Those things matter when it comes to health. And then we have to get to the individual. So what that individual lens looks like is that individual doctor who has a bias and is not going to prescribe a certain medication, or who will give one patient a test or an assessment over another. Because they have the ability to do so, they have the power to do so. That individual person's bias is a part of that system. And so I definitely want us to think about that big picture as we have this discussion today. So some of the alarming statistics that have come out lately are coming out of the Midwest, a lot of them. And I cover the Midwest. And so when they looked at Chicago, it showed that 70% of the deaths were African American. Same thing, very similar in Louisiana, with high rates of infection. But it's not just the infection, it's also the death rates are higher. As we know, what we know about COVID so far is that people who are vulnerable are the elderly, 65 and above, but also people who have underlying health issues. And those underlying health issues that are at the top are going to be heart disease, diabetes, obesity. And what we know so far about the disparities that are present with people of color, it's going to be those types of chronic diseases that are driving this pandemic, and is a reason why people of color and people living in poverty are more impacted. So I definitely want to talk about that in terms of ACEs, because ACEs science tells us that chronic disease is definitely being driven by stress in the environment and the experiences that we're having as children and also as adults. And so when we look at African American and Native American health outcomes, those two have the most historical trauma. also have the shortest life expectancy in our country. By far, there's a vast difference when we look at Hispanic, Asian, and Caucasian Americans. And so that huge difference is just an obvious way to think about how historical trauma is impacting those two groups. And that trauma is then embedded within culture, and it is pervasive in our society, how we view Native Americans and African Americans, what type of access they receive, what type of bias they experience, and then of course, even the overt racism that they may experience. So I want to definitely frame those conversations. Joshunda, do you want to add to that?
Yeah, no, I think you covered it really well. What I would add that I think is an important, a couple of things that I think are important to add to that framework include the economic structural issues that come to play related to healthcare access, right? So what we know is that, you know, despite the fact that there have been these conversations about deaths of despair among middle-aged white people, that is mostly driven by failures of healthcare access due to capitalism, right? And that the larger framework of how capitalism has perpetuated health inequities comes to bear in the percentage of people who are impacted in any given environment related to healthcare. So one example is, for instance, even though I was looking at data that said something about, like, even though white people are the majority, there's a poverty level like breakdown. I'm gonna drop it in the chat. It's they're like per capita, there's like a higher level of poverty because people don't know that most white people are poor, or that there are more white people who are poor in this country than there are African Americans. They don't really look at the disparity between the health disparities through a lens that includes money. But because money does inform so much of healthcare and healthcare access, it's important to remember that that actually impacts everything beyond even just medical treatment, right? You mentioned like access to healthy food, right? So I live in a food desert, so I have to walk actually across the bridge into Harlem to get healthy food or vegetables or anything like that. But that also means putting myself at greater risk, right? Because then I'm riding on the bus with essential workers and other people who otherwise couldn't afford to be on public transportation. And then there's also the whole issue of who gets to stay home, who doesn't, who can social distance, not even culturally speaking, but economically speaking, right? So I just think that there's also this kind of interrogation that we have to have about capitalism and its impacts on health equity.
Yes, that is definitely a huge impact. And so poverty is kind of the great equalizer. All races living in poverty are experiencing health disparities. But when we look at poverty within as a system, as we have an economic system in our country that makes it harder for people with disabilities and people of color to get loans to live in certain areas of town, to have, and then there's discrimination that prevents them from having jobs that allows them to have an adequate amount of time off, jobs that are not shift work or hourly. And so you have groups who are overly represented in shift work or essential during this time, right? And when we think about those groups are going to be full of young people. They're going to be full of people who have disabilities, and they're going to be full of people who are Black and Hispanic and Native American. And that's because of the amount of discrimination that they are experiencing when they interface with economic institutions and employment. One of the things that is going to be most prevalent during this time, because COVID is more impactful for men, which most chronic and most diseases in general are more impactful for men, which is why women have a longer lifespan. So when we look at demographics, the group that's going to be the most impacted by this are going to be African American men. who have more underlying chronic diseases, who are more likely to be represented in essential positions, who are still having to work in factories and in grocery stores and things of that nature. And they are just in general have the lowest lifespan in our country at 70 years. So you're going to see that they're going to be very impacted. And as someone, it seems, came up in the chat, we were talking about epigenetics, that epigenetic changes are due to historical trauma. And so the epigenetic changes that are present in Native Americans and African Americans, that has damaged, or what we would call kind of like speeds up the aging of DNA. And that's what causes those chronic conditions and issues around that. That is a result of historical trauma. And so it is definitely tied in with the reason why Native Americans and African Americans are experiencing lower life expectancy and are going to be impacted by COVID more than other groups.
There's one other thing I wanted to add to that, which is you probably have seen some of the news around face masks and face coverings for Black men in particular, for Black people. But if you haven't, there was a tweet from someone who said, I want to cover my face, but I want to live, but I also want to live, meaning that, like, just because you see me in a face covering as a Black man, I'm not trying to rob you. And I'm also like we can't like sort of look at self-protection or measures to follow CDC guidelines, which were delayed, but that's a whole other conversation. But outside of the context of racial profiling in this country, right? So now we have stories of Black men in Walmart in Illinois being followed by security guards who look at them and say, why do you have on gloves? Why do you have on a mask? Or why are you wearing a face covering? It looks like you're going to rob us, that kind of thing. So really making clear also that the inequities have not just to do with actual like access and treatment and all those things, but also they have to do with the other social inequities, that continue to kind of rear their heads as we make our way through this pandemic.
Allison, do we want to
talk
about some?
We did get one comment from Mary about epigenetics. So do we want to take a moment to talk about that? Mary, do you want to go ahead and let me, you can unmute yourself, Mary, if you just click there we go.
Thank you. I just wanted to add that one in because I think it's such a compelling part of the science about what we know about this American experience. And in the work that I do up here in northern Michigan, we're doing an awful lot with Native populations, and it's a very real part. And I just like to throw it in to make sure that we all talk about it. And if people don't understand the epigenetic implications, it's a biological imperative that really gets thwarted, isn't it?
Yes, and even here, as a part of the ACEs movement that we have in Nashville and Tennessee, people are wary to discuss epigenetic changes. And it has to do with just our history around saying whose genetics are better when it comes to people of color. And so when we talk about epigenetics, what that means is that when we experience our environment as human beings, not just Black people or Native people, all people experience their environment, not just through their eyes or their senses. You also experience your environment based on your DNA. So your DNA and your environment interact. When your environment is hostile, there are changes to your DNA where it's kind of like a switch that has been flipped. And when your environment is very comfortable and safe, then you don't get those switches flipped. So when people change, when their DNA changes based on the environment, if they have a hostile environment, what that looks like is that they are first very much driven to procreate and make more of themselves, but then also they are survival based. And it makes changes to their behavior, to their cognitive abilities and decision making, and it definitely ages their DNA. Once those changes are made in an individual that experiences trauma, they can then be passed on to future generations. And when we couple the DNA changes, which are the epigenetic changes, along with the cultural changes, so there's a whole culture that is built around trauma in Native and African American populations. This is the same thing with people who are LGBTQI. They have a whole culture built around their trauma. Same thing with people who are experiencing, who have disabilities. They have a whole culture that's built around their trauma. And they come up with strategies and adaptations to deal with their environment. And so you have the cultural component where they're adjusting to the stress and trauma of racism and discrimination and whatever hostile elements are in their environment. And then you have the actual changes to their DNA, which makes them have issues around cognitive ability and those chronic diseases that are associated with DNA aging. And that looks like high blood pressure, diabetes, heart disease. So epigenetics is something that we should talk more about, but I want to make sure whenever I talk about epigenetics that I give a very good disclaimer. So this is not about race, it is about environment. And so any group that would go through the genocide of Native Americans would have these changes. Any group that would go through slavery, chattel slavery, like African Americans would have those changes. And then of course, any group that is experiencing overt discrimination, like people with disabilities and people who are LGBTQI would have these types of changes. But thank you for bringing that up for sure.
Mary.
Joshunda, did you want to add anything when it comes to that historical trauma and how that plays a part in health?
Yeah, I mean, it's such a broad topic. I think that you really explained it very well. I know about epigenetics mostly in the context of the reporting that's happened, thankfully, around Black women who have trouble with maternity issues, dying basically at 3 to 4 times the rate of other mothers as a result of this sort of epigenetic stress and toxic stress, basically. That's like maybe, I think, the only factor that most reporters and researchers agree on as it relates to that maternal death, because even when you factor in education or economics or anything else, they still fare worse. You know, I thought it was interesting what you said, Mary, about the switches can be flipped back, because I think that there have been efforts to help with Black mothers in particular to improve their odds of living through childbirth. But I think that they've been slowed in part because of, I think there's been data that shows that a lot of the slowing of changing the impact of epigenetics has to do with assimilation, essentially, right? So that there are African women who come to this country whose DNA or their environment, because their environment changes and they're trying to assimilate to American culture, then their health begins to worsen in the same way that African Americans' health worsens. And so that's pretty discouraging to say the least, but I mean, I think it's not the only example. And you know, it's great to be thinking about how we can begin to reverse that toxic stress, because I'm sure that it's a model for other issues that we face.
Yeah, and I do want to go back to one aspect of historical trauma, that cultural piece that really kind of ties in to health really well, is the way that families are structured and the different parenting practices that are at play. One of the issues around African American men having such short lifespans is around the amount of stress that's involved in their upbringing, the type of parenting practices that are deployed. And this is something that is a common trope with Black parents need to be better parents, and that way to stop all these different things that are going on, youth violence, all the things. But Black parents parent in a way that they feel can ensure their child's survival in a racist system. But those parenting practices are being found to be detrimental to health. So when we think about Black boys being more likely to get corporal punishment, and we associate corporal punishment with the very clear research that shows that it is linked to these chronic diseases later in life, along with mental health issues as well. And so if these chronic diseases are going to be something that is fueling the amount of African American men having, high rates of death with this pandemic, then that is something to really look at. Parenting practices around Black children. And going a little further than that, when we think about all of these different ways that we are kind of enforcing chronic disease within the Black community and Native Americans, then we also have this other layer of cultural distrust of institutions. So Black people being less likely to believe the government when they say, this is how you protect yourself, don't go to, they're less likely to believe those types of things because they have an innate mistrust of the government due to historical trauma at the hands of the government. And so, and that would include medical health, obviously it would include legal and law enforcement. And so these, all of these types of things are kind of the perfect storm where you will see a lot of cases for African Americans and a higher death rate because of those underlying health issues. And so it's a very complex issue.
We did have a question here. So I wanted to go ahead and let Risa, okay, you are unmuted. So if you would like to add, we'd love to hear from you.
Oh, I would love a conversation if it's useful to others on anything people are learning, right now, especially as people are being quarantined in hostile environments, whether that's the house itself or the neighborhood itself. A lot of strategies that we've used with community collaboratives has to do with being in a public place or redesigning a public place to be more welcoming, and that's like a place of improving a neighborhood, for reducing violence, different things that require people to come together and be outside of their home. And so I'm just wondering, what are folks hearing or seeing that may be some promising practices, at least in the short term, and that may also inform our longer term strategies?
Thank you, Risa.
Yeah, that is a great question. And what I'm finding especially here in Nashville, but in general, one of the issues around health inequity and disparities is access. And so when you have practitioners who would normally be able to do a home visit, or you would have to come to an office and things of that nature, transportation, all those things have been limiting. And now everyone's moving to virtual communication. And I think that that's going to be promising moving forward. Even here in Nashville, we have students, right? Our schools are closed and they have virtual schools, and our teachers are having to text their students if they're old enough and they have a phone, or text their parents to keep up and keep track. That's going to be a relationship built that would not normally have happened. And it's the same thing with medical. We're seeing more telehealth and more, especially when it comes to mental health. And so I think this boom of telehealth is going to be something that helps people to feel more connected. And I hope that practitioners are using it as a time to build relationships. So I'm checking in with you about your health issue, or I'm checking in with you about your children. But while I have you, how are you doing? How are you coping with the stress right now? Are you using the coping strategies that we would talk about before when we were face to face? Are you implementing them and having hard conversations about stress, trauma, that they probably wouldn't normally ask, but now it feels more comfortable to ask because we are looking and seeking communication and connection with each other. And I think that that's something that will be positive, that hopefully will stay as we move forward. But the only implication of that is, yes, there's going to be more access because we're able to think, okay, if I can't meet this client or if I can't see them, I can do a teleconference or a video conference, or I can text them, which I would normally do, but now I can't see them in person, so I'll do that. Now we need to really think about the digital divide, those people who do not have internet access, who don't have laptops. Like, what does that mean for them in this time? And so access is a huge part of health equity. So.
Yeah, what I would add to that, I think, is I'm reading this book by Mia Birdsong. It's an advanced reader copy. It's coming out in June. It's called How We Show Up. And she talks about some people who live alone, for example, right? So I live by myself, I'm single. And, you know, shelter in place in a place like the Bronx is like not really a problem. It's fairly urban, but it's also kind of rural. It would be really easy for people to lose track of me, essentially, is what I'm going to try to get to fairly quickly. Unfortunately, right? So that can be a scary thing. And she was talking about her friend who has diabetes. And even though Mia herself is married, has children, has like a fairly like close-knit community, her friend, if something were to happen to her, that basically has no one really to rely upon. And so they came up with a system where her friend basically kind of let her know, you know, these are all the kinds of things that I would need. Like if I had a partner, it would be kind of common sense for that person to know that I needed this kind of medication, or, you know, if I needed my insulin shot, this is how I would get it, you know, in an emergency, these kinds of things, like a kind of a emotional go bag, if you will, some kind of emergency support, right? But so Mia became her person in that way, you know, to sort of say, you know, maybe you have multiple people in your life or multiple systems for people who can check up on you or who can text you. I know that there's been some concern about the uptick in domestic violence, for example, because of shelter in place. I've seen some agencies provide, I think they were doing this in the news environment, so I'm not sure if it's asynchronous, meaning that this is a video that someone can watch when their abuser is not around them. But I think that's also a great tool, right? To remember that just because you're live streaming something or you're having a teleconference at some time period doesn't mean that that person is safe to watch it in that time period. They may need to wait until their abuser is somewhere else or asleep or something like that. So I think those are really helpful strategies I've seen that seem like they could be promising.
Yeah, I agree. I think when I've had discussions here, and yes, safety planning is really kind of taking off. Like people are putting those different plans in place for their health, medications, who to contact, how to contact, you know, and I think that that is something that is really kind of taking off. Those contingency plans that they're putting in place now are things that will help them in the future as well once we get past this.
So I just invite anyone on the call, if you have a question or comment, we invite you to go ahead and drop that in the chat, and then we can call on you and invite you to participate in the conversation. And there's so many of us here, which is so wonderful. We're really grateful that all of you are wanting to participate in this conversation, and this is an important conversation to be having, and thank you for showing up with your valuable time. We value all of your comments and ideas and questions and concerns, so go ahead, throw them in the chat, and we'd love to hear from you.
So I have tons to talk about if no one has questions, for sure. But I do want to kind of think about, for the second half or less than half, thinking about what recovery looks like. And also as we move forward, because before, I work with a lot of collective impacts and consulting, and people are like, health equity, health equity, health equity. And it sounds good, and they are interested in the topic. They are very interested in diversity, equity, inclusion, and being very thorough with their movement so that they capture every community from a consultant point of view, but very rarely is it implemented. Because it's hard to do. It's hard to be inclusive. Our country is not set up to be inclusive. It is all about only white men succeeding in this country and white women by default, right? And so, so when we think about all other groups, women in general, people of color, people with disabilities, I want to stress how much when we think about disparities and access, how much that is. And so anyone that's outside of this structure is not getting everything that they need. And will we be purposeful when this is over, thinking about, okay, yes, in theory, we want everyone to get the same resources and the same, quality of life, but are we willing to do what it takes to get it done? So if, no one had to tell me before when this first happened that this would hit communities of color hard. When I said I wanted to talk about this was before any of the data was in. Once I understood that people who had underlying conditions, chronic diseases, would be more likely to pass away, I knew it would hit the African American community hard because we are number one in most chronic diseases. And there's a reason for that. It's not just individual lifestyle choices. It is because of systems that are set in place and bias. And even contributing to those lifestyle choices is the stress of racism, the stress of financial insecurity. That's also fueling those lifestyle choices as well. And so I hope that when we think about recovery, that we will be equitable. We will go back and right some past wrongs, because that's what equity looks like. It's not about equality. Equity doesn't look like equality. It looks like some people getting more, but they're getting more because they received less in the past. And you kind of have to give them more to kind of get everybody to the same starting point. And movements, even within the ACEs science world, movements are not willing to do that. It sounds good, but when it comes down to actually getting those things done, that's not what's happening.
Something I wanted to add, just as food for thought, it's kind of connected. I read this paper that I've been like thinking a lot about, and it's about essentially like centering whiteness in healthcare. And in it, the researchers essentially say that part of centering whiteness or white supremacy in our culture and the impact of it means that we kind of refuse to look at the differences between how different groups make meaning out of their experiences. So the example that they use essentially is that African Americans, for example, have a narrative of redemption, right? When things happen to us, we say that it happens for us, not to us, right? And that is our collective, generally cultural reaction to systems and structures and events that are outside of our control, which is pretty much everything. And that's true pretty much for everybody, but especially true for us. But for white people, there tends to be a cultural narrative of contamination, right? Something has happened to me to change me, and it is not my fault. Because when whiteness is not the power dynamic through which everything is happening, when white people are not in control, there is a feeling that some outside force has come in to usurp their authority and there is not the same feeling of it happened to make us better, or there's some kind of redeeming quality to whatever this disaster was. Instead, it is that outside force has taken my authority and changed the amount of power that I have. And I think that that's a fascinating framework to think about. I mean, these are researchers, one's from Harvard, one's from the University of Cincinnati, or Cincinnati, I don't know. I'm sorry, I don't know anything about the Midwest. I'm such a stereotypical New Yorker. But, it was a university in Cincinnati, sociologists who were looking at this framework and these narratives. And so I think, the important thing for me, the thing that came up for me related to that has to do with, everyone talks about the new world order, like the world that is going to come after this, and how things will change. The fact that they're not going to go back to normal. I think as we all absorb that, we're also all absorbing our own individuals and collective traumas, right? Like, this is actually an ongoing trauma that we're all in together, but we will all make meaning out of it differently, as we always have. And so, I guess the question is, what meaning we think that we individually and collectively will begin to make as we forge our way forward.
Yeah, that is a great point. That makes me think about tribalism. And so when that sense of contamination from outside, so when we think about this, will we move forward and think this all happened because of a Chinese virus? Or will we make meaning in a different way? And so, yes, that I definitely resonate with. The way we make meaning really helps us to kind of frame, do we feel like we have to find fault? Someone's at fault. It's because of this group, or it's because of that group, or if they had just stayed home, then none of this would happen. Or will we just say that if this happens again, we need to be able to prepare and make sure that everyone gets what they need, so we as a country don't succumb. So because people can't take time off when they're sick, we as a country are all at risk. Because some groups don't have adequate health care and have underlying conditions, we as a country are all at risk. And so that collective being able to overcome together versus the tribalism, which means it's your fault, not my fault, that this is happening. Yeah.
A couple things I wanted to call on Monique for your comment in just a second, but also Joshunda, the resource, or what were you referencing? I would be curious to follow up personally with that resource, and then to post it if anyone else wants to.
Yeah, I'll post it.
You'll post it? Okay, cool. Thank you. So Monique McDonald, if you could unmute yourself and share your comment, we'd love to hear from you.
Okay. Hi, everyone. My name is Monique. I'm actually in college right now at Tennessee State University, double majoring in both business administration and public health. And one thing that I definitely look into a lot is alternative medicine. So we all know that as far as our healthcare system, legal system, most things are kind of stacked against Black and brown people. So in that situation, do we look for alternatives for Black and brown people in the meantime, or should we just kind of wait until things get better for us? Like, I guess I'm trying to figure out another way to gauge that, because it's like, if Black and brown people are constantly getting killed, just like with in hospitals and things like that, like you guys were speaking about before, to go from us being killed, we have to find a way to kind of preserve ourselves. So is that in alternative medicine, including like CAM and things like that, or would that be, how do you guys feel that would look?
I think that's a good question. And I think there are a lot of implications in that, surely. Even when we think about when Joshunda was talking about Black women's health, so thinking about doulas as an alternative for Black women so they can get what they need that they're not getting from our traditional medical, and then even when we think about herbalists. So now, with it being very clear that African Americans, Native Americans basically have altered immune systems, or their immune systems are at risk. because of underlying conditions and historical trauma, thinking about what it means for them to think about holistic care and it being promoted in a way, because as we know, our standardized medicine is just like, it's very concrete. You know, even though some herbs will work, your doctor's not going to say, you know, you should go home and eat cinnamon to lower your blood sugar, even though it's whether it's proven or not, that's just not what they're going to do. And so I think that is something to think about. Also, we do know that mindfulness, yoga and other like meditative practices does heal DNA. And so that is something that definitely could be promoted within communities of color. And another thing that heals DNA that is very interesting that you might not think is just really being connected to your traditions. And so in, you know, maybe promoting that in communities of color. I know Native Americans and Indigenous people, that is something that they are struggling with. They want to hold on to their traditions. With their new generations coming up, they want to make sure that their traditions are passed along. And it is a protective factor, and it does heal DNA. And African Americans have such a disconnect from their traditions that they would struggle with that as well. So, but I think it's something to think about.
I'll just add that those are super helpful. I know that I just was looking at a Twitter thread from Tarana Burke, who's the founder of the Me Too movement, and she was talking about how her partner tested positive for COVID-19, and the fact that they weren't able to necessarily go to the hospital because of a number of different things. I mean, the healthcare workers and all the guidance in the city has been essentially, if you are asymptomatic and you think you have it, or if you have it and you're pretty sure that's what you have, then, you know, based on telehealth, you know, guidance or whatever, then just stay home. So she was talking about things like my boyfriend mentioned to me, which is that you should maybe use thieves oil to, you know, draw impurities out, right? Or, you know, she was like giving her partner medicine and NyQuil and, you know, over-the-counter things and other remedies, you know, natural remedies at home. So I think it's a both and situation, right? Like in this situation, a lot of the things that we can use to make ourselves well that we would use if we had a cold or whatever, we can, you know, try to employ if we think that we may have, you know, these symptoms. But I don't know that there is a replacement for like traditional healthcare, but I think that we can do both.
All right, we do have quite a few comments and questions now, so this is great. Jay Carlin, if you want to go ahead and unmute yourself, we would love to hear from you. And it's okay if you don't want to also. Jay wrote, when we talk about system, I encourage anyone with interest to read The System by Robert Reich, Supreme Inequity. Okay, cool. So dropping in some resources. Great. Thank you so much. Jane, our founder at ACES Connection, was just cheering you on, Ingrid. Okay, Maria, we invite you to unmute yourself and join the conversation. Maria Hamilton. Awesome.
I'm here. I had to find my mute button. The comment that I had, I'm going to actually start with the last one in response to the previous comment and what Ingrid has said and Joshunda has said as well, is that it isn't a either or, it is an and both, and particularly at this moment in time in this situation, and the connection to traditions is important, so that in the communities that I service as a healer and worker, people are having this conversation, but they're using the ancient things that they know, everything from divination and ritual to practices that are energetic, that are plant-based, to find a balance. Because if you're not finding service or not able to access the service in the traditional system, you have to rely on the things literally that your great-grandmother taught you that helped them to survive. And so I think that's really important. And also the interpretation and meaning making and rewriting the narrative moving forward is important, because that will also help us determine how to restructure where we are. I'm trying to get people not to think in terms of a new normal, because that also helps us to kind of settle physically and mentally and emotionally as this is normal, when it's not, whatever normal looks like. But it's, so just some of the things in my head at the moment.
Thank you so much, Maria. Ingrid, do you have a response for Joshunda?
I think language is super important. Obviously, as a writer, it's like all I think about. But thank you for that phrase, or explaining, pushing back against the new normal. I think part of trauma, part of grief means that you may not necessarily have language for the experience that you're in. And it's been interesting as an introvert, as someone who likes to spend a lot of time alone, to even find myself having the same collective anxiety, and also kind of jumping the gun, essentially, right? Like, when are we going to reopen? When are we going to, just having this, those triggers. I think that there is like a collective triggering of, okay, like, we've done enough of this now, it's time to move on. But it is all outside of our control. And that is a difficult place to, Maria, I like the way that you use the word settle. We're not able to settle into any kind of routine. We just have to go moment by moment, which is where meditation becomes helpful, where having ritual and having traditions and practices becomes really helpful, because you can ground yourself and find steadiness in that. I'm sure it's been helpful for me in getting through some of my own ACEs stuff, right? So yeah, I think it's really helpful to be mindful about language, in addition to all the other things and the signals that those words send to our brains about what is possible and what isn't.
Yeah, I agree with the, not exactly pushing back on new normal, but definitely, if every time we've had a pandemic in the past, I'm big on history. So, every time we've had pandemics in the past, we've had huge changes in our society. We used to throw human waste in the streets. We used to spit in the streets. We used to throw human waste in our water supply. Now, after this, I'm hoping that what we adjust is going to be how we take care of our vulnerable populations. So, especially when we think about viruses, for the HIV/AIDS epidemic, right? We were total, when I say we, I mean us as a country, we're totally fine with letting a group of people deteriorate, as long as it wasn't us, right? And then once it got to the point where it was so bad within that group that it became an issue for the whole country, we would have to get better in this, where we understand that we need to protect vulnerable populations, not just because we are altruistic and care about everybody, but even for self-preservation, the understanding that we are all the same type of organism. And so when there's problems within the human organism, it's not going to stay in one spot. It's not going to stay just over there with them. It's going to be a problem for everybody.
All right, we are reaching the top of the hour here, and so I just want to invite Ingrid and Joshunda to share any closing remarks as we wrap up. I just want to express so much gratitude for everyone who has joined us today. ACEs Connection is a community, and you all make our community, and we're so grateful. I wanted to, before I turn it over to them for closing remarks, I wanted to just share a couple of things about ACEs Connection with you. So one thing that people may not realize is that we have communities that you can join on our site. If you go to acesconnection.com and you join as a member, I think probably all of you are members, but just so you know, just in case you can hear another avenue, you can join as a member. Then if you're a member and you're signed in, you can post to our website. You can join communities by clicking the communities button in the upper left-hand corner, and that's regional communities, and it's also interest-based communities. So Ingrid, what's the name of the one that you just started? What's on racial? Is it African Americans in?
So the one that I just started was African Americans and historical trauma.
Okay, cool.
And so that is a new community that I haven't been able to invest a lot of time in because as soon as I started it, we have a pandemic. So, so yeah, I definitely have pivoted. But yes, there will be more information into that group and more activities and events coming out of that group.
Yeah, so we invite you to join that community if these issues are important to you, and that way we can keep the discussion going within that community. If you have any questions about how to join a community in your region, you can reach out to me and or Ingrid and or the community facilitator in your area, and we're all listed on the homepage by region. So I'm the Northeast and Mid-Atlantic, Ingrid does the Midwest and Tennessee. So please feel free to reach out to us with any questions about how to get more involved, because we would love to continue this conversation with you. And I just want to empower you all, because not every member realizes that you yourself can post original content to our website. And that's what makes our network so powerful, is the member engagement. So I just invite each and every one of you to do that. You just may not know that you can, but you just click the post button when you're all signed in. So okay, so now some closing remarks, Ingrid.
So just very briefly, I just want to thank everyone for taking their time to have this discussion. I want to be very clear that this was in no way in depth. This was just an hour. There's a lot to talk about when it comes to health disparities. Each one of these things that we've talked about could be its own. And so we will have other opportunities to interact around these disparities, health or otherwise. But I do just want to challenge everyone, especially if you are in an ACEs movement in your local area, that you take equity into account. Don't just reach out to people who look like you in your neighborhoods, in your profession, but really stretch yourself to reach out to vulnerable populations and make sure that your efforts are closing the gap on disparities, not perpetuating them.
I just want to thank you for inviting me to be part of this conversation and to learn more about what's happening in other parts of the country, because New Yorkers, we can be insular and not as aware of what movements are taking shape and what thoughts are happening outside of the Northeastern bubble. So it's nice to hear always from you, Ingrid, but also to hear what's happening in other places. So thank you so much for making the space for us to have this conversation.
Thank you so much, Ingrid and Joshunda, for leading this amazing conversation. And thank you to everyone who chimed in with your comments, questions, concerns, and resources. Amazing. Thank you for being a part of this community. And then I see some comments, Professor Ingrid, so some students here, which is so cool. We are so lucky to have Ingrid at ACEs Connection. And so I did drop our emails in there, so feel free to reach out. And I hope that you all have a wonderful Thursday. And I hope to see you again. We're doing one tomorrow as well at the same time. You can find information about that on our homepage, and we hope to see you again.